on the topic like today I'm going to discuss about the confusing lungs. So in this any baby presenting with the signs of the respiratory distress is not always our straightforward diagnosis preterm in the preterm RDS and in the term congenital pneumonia, but we have to also think of the another congenital malformations diseases. So first of all, with starting with our discussion, we will go with the some of the cases scenario that has come admitted to our hospital, and so let us start with the story of the 4 babies that was admitted in our hospitals. So first case, term baby was referred on the postnatal day 20 with the fever and cough for 5 days. With the family history of upper respiratory tract infection. On examination, baby was tachypneic with the subcostal and intercostal retraction. SpO2 was 92% in the room air, and on examination, occasional crackles bilaterally was present and predominance on the left side mainly. Investigation by high CRP was there with the neutrophilic predominance count, and clinical impression of the acute bronchiolitis with the suprahead bacterial infection was made, and initially the baby was on HF support with 30% FiO2, and started on IV antibiotics, cefuroxime, and antiviral oseltamivir was given. As antiviral was started because at that time in our unit bronchiolitis outbreaks was there, and with the family history of URI, we have added the oseltamivir. And initial X-ray was taken that was showing the bilateral patchy opacity with the right lower lobe
just a
collapse
second.
was there.
Just a second. Requesting all participants to kindly stay muted. Okay.
So next day, there was a clinical worsening in the distress, and X-ray was again taken. Repeat X-ray was showing hyperinflated lungs on the right side with the overcrowding of the ribs on the left side, and a possibility of the compensatory emphysema with the herniation to the left lung was there in this X-ray. So hospital course of that baby, like baby was continuing for HFNC for the 3 more days, and laptop position was given. Repeat X-ray was showing better, and bilateral that patchy opacity was resolved also. So initial that was initial diagnosis now confirmed to the bronchiolitis with the left collapse and compensatory emphysema, and that baby was discharged on day 6 of the admission. Now coming to the second case, that second baby, 17 days old term female baby was referred with the complaint of the cough and breathlessness for the 1 day. Uneventful antenatal period and discharged on day 5 from the local hospital. And on day 16 of the life, the mother noticed the baby to have the cough and increased burst of breathing and history of also low grade fever but that was not documented. Initially taken to the nearby hospital, and on the basis of clinical examination and history, acute bronchiolitis with suprahead bacterial infection was made. Baby started on nasal CPAP and IV antibiotics. As the condition was progressing, referred to the next day to the our hospital. On examination, when this baby admitted to our hospital, on examination, baby was euthermic, good perfume was there, but increased burst of breathing was there with the subcostal intercostal retraction with the respiratory rate of 88 per minute and Downey score of around 5/10 at the time of admission. SpO2 was at room air was 88%, and that baby was put on the NIV-IMV mode with the PIP of 18/5 and SpO2 of 40%. On that, the respiratory distress of that baby gets settled, and Downey score of after putting on NIV comes to be 2/10. So initial diagnosis of this baby also like similar pictures. Our initial impression was acute bronchiolitis. Second was late onset neonatal sepsis with the pneumonia. X-ray was taken, and the X-ray was showing left-sided hyperinflation with the mediastinal septum, and right upper zone collapse was also there. That most possibility of the thymus thymus shadow. Initial BBG was taken that was showing mild respiratory acidosis, and investigation wise only lymphocyte predominance was there. CRP was non-reactive at the time of admission. So acute bronchiolitis with the collapse on the right side with the compensatory emphysema on the left was made, and the baby was started on the IV antibiotics and other supportive management. Initial status for the baby for the 2 to 3 days remain the same, and next day the repeat X-ray was taken. That was again showing the same picture: hyperinflated lungs with the mediastinal septum with the clear vascular marking. So here the pneumothorax can be ruled out as the vascular marking is clear, and also there is no collapse of the lung. Only the hyperinflation is there. So so after the X-ray, our diagnosis comes to be like compensatory emphysema or the congenital lobar emphysema. Pediatric surgery opinion was taken regarding that persistent X-ray finding of hyperinflated lungs, and clinical condition improves gradually on day 5 made off support. But the repeat X-ray was again taken on day 5 of the admission, and this again showing the same picture. There is no resolution of the hyperinflated lungs. The same picture is coming in the both all the 3 X-rays with the hyperinflated lung filled with the mediastinal septum. So so CT chest was advised for this baby. CT chest showing hyperinflation of the entire left lung. There is a partial collapse of the left lung with the, here is a partial collapse with the left lung with the mediastinal shift to the right one. So features, this CT is showing the features of congenital lobar emphysema. So diagnosis of finally after the CT, the congenital lobar emphysema was made on this baby. Next day, baby was taken for the left thoracotomy with the upper lobectomy done. Here the green arrow mark is showing the CLE, that hyperinflated emphysema, and blue one is showing the normal lung fields. And after the post-surgery, X-ray was taken. That was now the bilateral lung field is expanded and the left side hyperinflation was clear. So here we can compare the 2 X-ray. In the first X-ray, that our first baby, here also the hyperinflation on the right side was there with the overcrowding of the lips on the left side. And in the second X-ray, hyperinflation of the left lung was there with the mediastinal septum was there. But in the initial, our diagnosis was in the first baby was the bronchiolitis, and in the second baby, it's tends to be finally CLE, congenital lobar emphysema. So from this we can say we can say that every breathlessness with hyperinflated lungs cannot be always bronchiolitis or pneumonia. It can be congenital lung malformation also. So always hyperinflated lungs with the collapse is not a bronchiolitis or pneumothorax. Think of the congenital lung malformation also. Now coming to the third case, 18 hours old term female baby, birth weight of 3 kg, delivered by the normal vaginal delivery, was referred in view of respiratory distress at 6 hours of the life, and X-ray was showing left-sided pneumothorax. Baby did not require resuscitation at the birth, and no significant antenatal history was there. At 6 hours of the life, baby was having increased bulk of breathing, started on nasal cpam and IV antibiotic. But as there is no improvement in the distress and falling saturation, baby was intubated and X-ray was taken, which was showing left pneumothorax, and ICD was inserted and referred to our hospital. At the time of admission, on examination, baby was euthermic, activity was good, CFT was less than 3 seconds, and respiratory part, Downey score of 1/10, respiratory rate 48 per minute. So initial on the basis of X-ray and the history and examination, our initial diagnosis congenital pneumonia, second was a spontaneous pneumothorax, and third was congenital lung malformation leading to the pneumothorax. At admission, this was the admissions X-ray, which is showing no pictures of pneumothorax. Left-sided lung is expanded, and ICD we can see here. ICD is there inserted in the left side of the lung field. ICD is in situ. So this was the initial X-ray taken when the baby was referred to our hospital from the nearby hospital. Hospital course, the baby was extubated and kept on the room air on the same day, and post-extubation SpO2 was 95% at room air and heart rate was 124 per minute. Repeat X-ray showing expanded lung field and ICD removed at 50 hours of the life. But the baby developed again respiratory distress after the 30 hours of the ICD removal. So this was the after 30 hours of the ICD removal, baby has again developed the pneumothorax, with a hyperinflated lung on the left side with absent bronchovascular marking with the shifting mediastinal shift to the right. So again the ICD was reinserted, and due to the recurrent pneumothorax, CT chest was advised. CT report of this baby, CT chest well defined. Here we can say clearly is a well defined thyroid air density cystic lesion in the anterior basal segment of the left lower lobe. Possibility of the congenital pulmonary airway malformation type 1 was made on the CT. So baby was weaned off respiratory support. ICD was clamped and observed for 24 hours before the removal. As per discussion with the pediatric surgery and the radiologist, cystic lesion can be unresolved pneumothorax in the oblique fissure. That was commented as a cpam in the CT. So hence CT again advised after 2 weeks to look for the clearance of that. But baby was stable in the room air and discharged after the 3 days of the observations. This is the X-ray before the discharge of the baby. X-ray is showing bilateral expanded lung field with no pneumothorax. But that baby has to come after 2 weeks in the follow-up. But after the discharge of the within 3 days, that baby was again got readmitted with the severe distress, and X-ray was showing left pneumothorax. Here we can see it's again left pneumothorax with absent bronchovascular marking with the mediastinal shift to the right. So again the ICD was inserted and distress gets settled soon, and blood investigation was sent. That was not within normal range. So after the initial stabilization, baby was taken for the thoracotomy and shows cystic lesion involving the left lingular anterior and the posterior segment. Here we can see the cystic lesion. Like here the cystic, multiple cystic, here once multiple cystic lesions are there. So left lingular segmentectomy done and the specimen sent for the histopathological examination. So histopathological examination, so lungs with the multiple cystic spaces lined by the ciliated columnar epithelial suggestive of the congenital pulmonary airway malformation type 2. In the CTs was mentioned 2, but in the histopath examination, it's like multiple cysts is there and lined by the columnar epithelium. So the type 2 cpam diagnosis was made. This is the normal histopath of the structure of the lung. Here we can see the contour is maintained. This is the normal contour. But in here we can see due to the multiple cystic lesion, the contour of the normal lung has distorted, and here we can see the multiple cyst is present in this histopath, and here we can see the this cyst is lined by the columnar epithelial cells. So post-op no complications was there, and baby finally discharged with the stable vitals. Now coming to our fourth baby, baby of Swayama. The term baby referred with the respiratory distress soon after the birth. X-ray at the time of admission showing right lung collapse. So our initial impression was congenital pneumonia with the right lung collapse. But as the baby was not improving and serial X-ray was taken and there is no improvement in the X-ray, and hence right lung agenesis suspected and CT chest was advised. CT chest showing the right lung agenesis. Here we can see agenesis of the right lung is there. So our final diagnosis of lung agenesis for that baby was made, baby of Swayama, and final outcome of that baby is discharged, and that baby is still in follow-up of our clinic. So by this all cases we can compile here that all the respiratory distress presented in the newborn cannot be like a simple it's initially we can think of the normal diagnosis like a pneumonia or RDS in the preterm, but it's not always the RDS or pneumonia. If it is not improving on the X-rays, serial X-rays showing the similar pictures, then we have to think of the congenital lung malformation also. So today, what we have seen in our all the 4 cases, one baby is only having the bronchiolitis and other 3 babies having congenital lung malformation. So now we will come to our discussion part that today we will discuss about the congenital lung malformation in the newborn. So under this discussion, we will discuss with the definition of the congenital lung malformations, embryology, classification of the congenital lung malformation, diagnosis and management, and take home message. So congenital lung malformations. Congenital lung malformation is a heterogeneous group of the rare disorder that includes cpam, that is the congenital pulmonary airway malformation, pulmonary sequestrations, bronchogenic cyst, bronchial atresia, and congenital lobar emphysema. Embryology is divided into the six phases six phases. One is the embryonic, one is the pseudoglandular, canaliculaire, saccular, alveolar, and microvascular. So these are the pictorial representation of the different stages of the lung development. In the embryonic phases, mainly the lung bud differentiations, trachea and the bronchi, pulmonary veins and arteries are found. It is starting from the 4th to 7th week. And pseudoglandular phase, conducting airway, terminal bronchioles, immature neuronal networks, and pre-acinar blood vessels are also found, like 7 to 17 weeks for the pseudoglandular. In the canalicular, primitive alveoli and type 2 Clara cells are formed, and surfactant synthesis start from this phase only. This lasts from the 17 to 26 weeks of the gestation. Saccular phase, alveoli, saccules, extracellular matrix, and neuronal networks and maturations occur in this phase, and this lasts from the 27 to 36 weeks. Alveolar phase, expansion of the gas exchange and nerves and capillaries are found in this, and this will continue from 36 to 2 years. And the last one is the that microvascular, that last from the that start from the hair only, this alveolar phase only, like nerve and capillary are formed, and this continue till 18 years of the age. Like vascular formation in the lungs can it can continue till 18 years of age. So after the embryology of the lung and different stages, different phases, we can see in this diagram what are the different stages and what are the different congenital anomalies can be developed in the different phases. So we can see from here that in the embryonic phases, like pulmonary agenesis and lower agenesis can occur. In the pseudoglandular phase, cpam, congenital pulmonary adenoid malformation type 1, 2, 3, and bronchopulmonary sequestration can occur in pseudoglandular phase. And in the canalicular phase, pulmonary hypoplasia can occur, and in the type 4 cpam can occur in the alveolar and the saccular phases. So these are the pictorial representation of different stages of the lung developmental, and what are the congenital malformation can occur in the different stages of the lung development. So now coming to the congenital lung formations, so 90% of the lung lesions are mainly compromised by the mainly composed of the three things. One is the congenital pulmonary airway malformation, another is the pulmonary bronchopulmonary sequestration, and the congenital lower emphysema. Now coming to the classification of the congenital lung lesion. So it is divided into bronchopulmonary malformations. It consists of the bronchogenic system, bronchial atresia, congenital pulmonary airway malformation, and bronchopulmonary sequestration. Then congenital lower emphysema and other cystic lesions like enteric cyst, mesothelial cyst, and simple parenchymal cyst. Now coming to our most important congenital malformation, that is the congenital pulmonary airway malformation. cpam is a non-functioning cystic lesion. Prevalence at birth is 1:8,000, and more than 80% diagnosed antenatally. Most common congenital lung lesion account for 25% to 30% of all the CLM. It's mainly prevalent in the male and mostly sporadically. Lesions in the cpam are mainly hematomatous, contain cystic and adenomatous elements connected to the tracheobronchial tree, and have blood supply from the pulmonary circulation as well as urinator and limited to one lobe only. So these are the cpam classification. There are 5 types of the cpam, type 0 to type 4, Stocker classification, classified pathologically according to the level of the insult of the airway and the different stage of the lung development. Here we can see type 0, that is the involvement in tracheobronchial, type 1 bronchial, type 2 bronchiolar, type 3 alveolar ducts, and type 4 distal acinar will be involved. So now coming to the Stocker classification of congenital pulmonary airway malformation. Stocker has divided the 5 type of classified the 5 type of the cpam, 0 to 4. Most common among this is the type 1. It accounts for 60 to 70%, and least common is the 0, type 0, that account for less than 2%, and this is type 0 is the most lethal also. Type 4 is associated with the genetic predisposition for the carcinoma in the family also. So our baby was having type 2 cpam because that baby was having that histopathology is showing multiple cysts was there, and that was lined by the columnar epithelium. So our baby is having type 2 cpam. That I've already discussed. So now the prenatal classification for the practical purpose, generally the cpam is divided into two parts. One is the macrocystic lesion, another is the microcystic lesion. Macrocystic lesions more than 5 mm and microcystic less than that. Now coming to the cpam clinical presentation. So cpam 33% diagnosed later in the childhood due to the complication, and prenatal presentation, it can be in 5 to 40% cases of fetal head drops will be there, and 66% asymptomatic at the birth, and 25% may develop symptoms at the birth, like respiratory distress. Now coming to the diagnosis and recommendation for the cpam. So family history of the tumor, cystic lesion, and type 4 genetic predisposition is there, and prenatal ultrasound and prenatal MRI is also useful. Chest X-ray for all the patients. Single lesion, if the single lesion of the large air-filled cyst, it can be type 1 and type 4 cpam. A small numerous air-filled cyst will be in type 2, and large solid mass type mass is present, then it's a type 3. But the plain X-ray often fails to detect a cpam in asymptomatic patients. For that, CT chest and chest MRI is needed. For symptomatic patients, pre-operative, or for the asymptomatic patient at the 6 months of age or earlier, if in the high risk for the complications. There are different high risk complications. So one is the large lesion, another is the bilateral multifocal cyst, family history of BPP, that is the pleuropulmonary blastoma and pneumothorax. Definite diagnosis of cpam is by the histological examination only. This is the imaging showing the cpam. Initially, we have also see that that images of our baby. This is the same. Here in the CT, we can say see that multiple cysts are present in the right lobe, and here also we can see in the X-ray that multiple cysts are present in the right upper and middle lobe. So now coming to the that growth pattern of the cpam after 28 weeks get smaller, and one of the most important thing prenatally is the CVR ratio. That CVR ratio is the cpam volume ratio. In this, the volume of the cpam is calculated and divided by the head circumference, and its value is coming less than 1.6, then the chances of head drops will be the less than 3%. If it is more than 1.6, it will be chances of head drops will be more than 75%. So microcystic cpam is will respond to the steroid administration, and macrocystic no consistent response is there, and this needs thoracoamniotic stenting. This is the pictorial prenatal management of the cpam. Here we can see if there is any associated anomalies with the cpam, we will counsel the parents because the prognosis is very bad in these cases. And detailed sonography and MRI and fetal echo, on that isolated cpam was confirmed, and if the high risk is present, that cpam volume ratio more than 1.6, then we have to look for that is microcystic or microcystic or no large cyst is there. Then if the microcyst is there, and we can take the trial of the steroid, because we have already it's in the microcystic there is the definite role of the steroid. So trial of the steroid taken in the microcystic cpam, and if there is a head drops or possibility of no head drops will be there. So less than 32 weeks, if the head drops is not there, then we can if the head drops is there in the less than 32 weeks, we can go for the open fetal surgery and thoracoamniocentesis if the lesion is microcystic, and if it is more than 32 weeks, we can go for the exit to the cpam dissection. So basically, this chart is showing that we have 3 prenatal management option for the cpam. One is the steroid trial, another is the open fetal surgery, and another is the thoracoamniotic shunt. That depend on the lesion and also depend on the gestational age. If it is less than 32 weeks with the head drops, we can go for the open fetal surgery and thoracoamniocentesis. And if no head drops is there, we can if it is age is more than 32 weeks, we can go for the exit. So role of the prenatal steroid, the resolution of the hydrops after the maternal beta-methazones administration was noted. Like several other reports have the same effect with the 2 standard doses of the 12 milligram of the beta-methazones intramuscular 24-hour apart, showing the decrease in the cpam growth lesion with the cpam volume ratio more than 1.4 at 19 to 26 weeks of the gestation. But the mechanism how this steroid work in decreasing the size of the this cpam is not known. Basically, they assimilate probable reason should be like stimulate the maturation of the lung cells, and other possible cause could be like steroid effect affects the cell proliferation and apoptosis, and thus reducing the cpam growth. Now coming to the, these are the antenatal management, and now coming to the postnatal management of the cpam. One is the symptomatic. If the symptomatic is there, we have to go for the surgical corrections. Lobectomy is the preferred, and segmentectomy only if the anatomically feasible. There is an approach called Gauss approach to the asymptomatic cpam. That is the approach. This was developed by a hospital. That is the approach to the great street hospital. In this, we can say asymptomatic patients, like assessment of the asymptomatic cpam. We have to see the assessment in the different phases. In the prenatal period, detection of the CLM should be done. In the neonatal period, clinical assessment plus X-ray has to be taken, and within 6 months, one CT has to be taken. Clinical follow-up every 6 to 12 months, and at the age of 5 years, one CT scan repeat has to be taken. These are the asymptomatic cpam management, and we have to go for the only the observation. But if any state, like if baby has developed like respiratory distress, large mass leading to mediastinal shift and not corrected by the conservative management, then we have to go for the surgical correction. So after the cpam, we comes to the we will discuss with the congenital lobar emphysema. This is characterized by the overinflation, the distension of one or the more pulmonary lobes with the compression of the adjacent lung. Etiology wise, 50% is unknown, and 50% is due to the dysplastic bronchial cartilage. This is the X-ray of our baby, that CLE baby, that is showing the hyperinflated lung on the left side with the mediastinal shift to the right. But as the bronchovascular marking is prominent, and also there is a no collapse, so diagnosis of CLE was made. Later on, due to the confusion, we have taken the CT also. The CT is showing the hyperinflated lung on the right side, left side. So most frequent site for the congenital lobar emphysema is the left upper lobe, followed by the right middle and upper lobe. And prenatal discrimination between the cpam and CLE is somewhat difficult. So complications like polyhydramnios and hydrops are not associated with the CLE. This is mainly associated with the congenital pulmonary adenoid malformation. And acquired lobar emphysema like barotrauma has usually led to the right lower lobe and right lower lobe CLE will be there in the barotrauma. Now coming to the another topic, that is the pulmonary sequestration. A pulmonary tissue isolated from the normal functioning lung has blood supply from the aberrant systemic artery. It can have a histology of cpam type 2 in that 60% cases. This pulmonary sequestration can be of two types. One is the interlobar and one is the extralobar. Here is the interlobar and here is the extralobar. So intralobar pulmonary posterior basal segment of the left lower lobe, we can see here, and diagnosed later after the adolescent period only, associated with the other malformation. And the extrapulmonary that is also like beneath the left lower lobe. Here we can see 50% are abdominal also, and diagnosed by in the infancy because of the associated malformations. So here we can see the pulmonary sequestrations X-ray pictures. Here is the interlobar pulmonary sequestration. Arrow mark is showing the pulmonary sequestration, and in the CT also, in the this yellow arrow is showing the interlobar pulmonary sequestration. So after this, we will discuss with another topic, that is the bronchogenic cyst. This cyst developed from the abnormal budding of the tracheal diverticulum or the ventral aspect of the primitive purgate. It may or may not communicate with the airway, and it can be present in the variety of locations. Histology by this is this bronchogenic cyst is thin walled with bronchial epithelial lining filled with the mucus, and it can be diagnosed prenatally by the USG. So this is the X-ray picture showing the bronchogenic cyst. Here we can see in the left lung, the well-defined margin is there of the cyst. And in the CT also we can see here that well-defined margin of the cyst is there. So now coming to the diagnosis and management part. So prenatal detection of the congenital lung malformation increases with the technology improvement. Now the prevalence of the prenatal detection of the congenital lung malformation is 4 per 10,000 births. A smaller asymptomatic lesions can be identified. The first congenital lung malformation was diagnosed antenatally was cpam in 1975 in Australia. So these are the antenatal management of the congenital lung malformation that we have already discussed about that cpam. In the interlobar sequestration, like interlobar sequestration, we have to, like, antenatal periods are unwanted, only observation is needed in the antenatal management. And in the extralobar sequestration, that is best treated after birth, the only surgery has to be performed in these cases. For the congenital lobar emphysema, serial monitoring is there if the baby is asymptomatic. Otherwise, surgical correction needed if the baby becomes symptomatic. For the bronchial atresia, if the head drops before 30 weeks, open fetal surgery has to be done, and head drops after 30 weeks, exit resection has to be done. Now coming to the postnatal management of the congenital lung malformation. In this, we have already discussed about the congenital pulmonary alveolar malformations. So we will, for the bronchopulmonary sequestration, only surgical treatment is there for the postnatal management. And congenital lobar emphysema, asymptomatic cases, only conservative management and observation is needed. And in the symptomatic cases, open lobectomy is the preferred surgical choice. For the bronchial atresia and bronchogenic cyst, thoracoscopic or open resection should be done. So this is one of the original article that showing the natural history of the prenatal diagnosed congenital cystic lung lesion in long-term follow-up in 119 cases. This study show the result in the cases of cpam, we can go for the conservative management also. Like 57% patient goes with the conservative management and the surgical 43% with the surgical management. Among this conservative management, 10% was discharged and 6%, almost 6% has a spontaneous resolution of the cpam, and 76% asymptomatic and continue follow-up till 10 years of the age, and 12 to 5% lost to the follow-up. Surgical treatment, 6.7% emergency surgery was done, and 36% beyond neonatal period. They are in the follow-up. 17 went for the elective surgery because of the CT concern. And another 9.2% recurrent infections was there, and 4.2% unclear. So basically, with this study, we have we come to the conclusion that that congenital malformation, congenital lung malformation can also be if there is a symptom is not that much worse, and we can observe for the conservative management also. And if the like condition is not improving and the baby is becoming bad only, then we will go for the surgical corrections. So now take home message. As the technology develop, our ability to identify the congenital lung malformation antenatally has improved. cpam is a rare congenital lung malformations, and clinical presentation can be asymptomatic. There is a controversy about the how to manage asymptomatic cases, and conservative approach is also possible. We will go only with the baby's symptomatic as not improving with the conservative management. We will go with the surgery. So a long-term follow-up and the further study are also needed in this. So our future directions, like prenatal management. So like antenatal aspect that I have already discussed for less than 32 because we can try in cases of microcystic cpam. Thoracocentesis will be the another option. Early delivery and partial delivery to exit procedure, and in utero resection should be there. Sclerotherapy is the other upcoming therapy in the prenatal management. Thank you for listening.
Thank you, Nikhil, for that good presentation. Beena, madam, we have Dr. Beena SV. Madam is a professor of pediatric surgery in Government Medical College. Madam, can you give some expert comments?
Yeah, Nikhil, that was a very extensive review of literature, and that was a very good presentation. In the case of CLE, Did you see the compressed lung seen in the left chest?
You can show that.
That is a, yeah. The CLE, no, previous X-ray. Yeah. So these are the three hallmark findings in lobar emphysema. That is the overinflated lung, where you may mistake it for a pneumothorax, but you are seeing the vascular markings. Then you will be seeing the compressed lung. If the upper lobe is involved, you will see the compressed lower lobe and the mediastinal herniation, herniated lung. So these are the three findings which clinch the diagnosis of a CLE. So always you will have a differential diagnosis of a mucus plug obstruction. So if, in respect to cpam and the pulmonary airway malformation and CLE, surgeons will choose to operate CLE first, because these CLE patients, you can see the lung which was popping out, the operative picture now. So this was causing compression. So this surgery gives rapid relief for the child. So, but in cpam, in the pulmonary airway malformation, the problem is even there are cysts as well as normally functioning lung in that lobe. So a lobectomy in a pulmonary airway malformation may add to the distress for the child, because we are removing some areas of the lung which were supporting the oxygenation of the child. So that is the problem with the surgery on a cpam versus CLE. So that is why many of the cpams which are antenatally diagnosed are conservatively managed if the child is asymptomatic. Only if the child is symptomatic, we need to proceed for surgery, because the whole of the lobe is not involved in this cpam. In this case, we could do a segmentectomy, but it may not be possible always to do a segmentectomy in cpam. If segmentectomy is possible, you are removing the diseased portion of the lung and retaining the normally functioning lung. So that will keep the baby, the ventilation perfusion will be retained for that. So that is the problem with cpam. So when a cpam, when you need, your intervention should be decided. Actually, we are not doing the ventilation perfusion scans. Did you mention about that? Actually, that also has to be done. So before you are proceeding with a lobectomy, you should identify how much of that lung which we are going to remove is already participating in the ventilation perfusion, so that we can have an assessment. That is not mentioned. We are also not doing it, but that will give a very fair idea how much of the lung is working of this lobe involved with pulmonary airway malformation. So that is the thing with cpam.
It's a rare presentation, right, madam? Because this baby had 3 episodes of pneumothorax and was not accurately diagnosed.
That lesion was very superficial. That is why we could remove it with the segmentectomy. Very superficial, and probably the major airways were not involved. So that is why the air leak was slow, and that is why the child became symptomatic in 3 days gap. So it was a slow air leak, but it was looking like small blubs only on the lung. But anyway, the report has come as a airway malformation. Pathology report has come as like that.
Yes.
Okay.
There is a query on what is the prognosis of cpam associated with high drops?
Eye drops. I don't have any experience on that.
It would probably be very bad, I feel. We have also not had a cpam presenting with high drops. Most of the cases of cpam that we have are asymptomatic. Most of the so-called antenatally diagnosed cpams did not present in the neonatal period. So, ma'am, when you see them as old, when infancy, and
I think many are antenatally picked, and we follow them up. We do chest X-ray. Many will show normal X-rays. So some will show the cystic changes, and like a honeycomb appearance will be seen. Then if the child is symptomatic, we will do a CT early. Otherwise, we will wait. I think we have so many children on follow-up. Asymptomatic children antenatally diagnosed as a pulmonary airway malformation. Actually, I had a bad experience of a CPAM. A 6-month-old child I took up for surgery. Actually, baby was asymptomatic. But I did a right upper lobectomy. Actually, the cystic areas were involving only almost half of the lobe I removed. But the baby didn't survive. It succumbed after 3 weeks. So that is a problem. So whenever I take up the child for a lobectomy for a airway malformation, I tell them these children will have distress, will have increasing distress, because some normally functioning lung is also removed. And some children, they will recover from this distress in 2 or 3 days. Some will have this distress. Some cannot cope with that lobectomy. So that is a problem with this airway malformation. Bronchogenic cyst and small air pocket. How to differentiate? Bronchogenic cyst is usually seen as it is not seen as an air pocket. It is actually it presents as a mediastinal mass, not like a CLE or a CPAM.
Any other questions or queries that Madam can answer? So thank you so much, Beena ma'am. I think both the cases were operated by ma'am, and so today's main highlight was we wanted to, where many of the cases with improvement in antenatal diagnosis, many of these cases are picked antenatally. And but our cases, both these cases were not detected antenatally, and they presented as respiratory distress in the neonatal period. So initially we would go with the line of other commonly diagnosed congenital pneumothorax, and the other baby presented later on. So we were thinking of bronchiolitis. But when the child did not respond to the common conventional management, then we had to think out of the box and realize that it was an underlying lung malformation, which was confirmed by CT of the chest. So we just wanted to present the different presentations of congenital lung malformations that we had been seeing recently. So thank you everyone for joining. And once again, congratulations, Nikhil, for the good presentation. Are there any other, if there are no other queries, I think we can wind up. And Aswathy, you want to add any comments?
No, ma'am.
So thank you all. And thank you once again. Beena ma'am, thank you.
Thank you.